A 28-year-old woman presents to A&E with a 4-hour history of lower abdominal pain. She rates the pain 8 out of 10 and she's feeling very unwell with loss of appetite, nausea and vomiting. She has a history of PCOS and has been receiving fertility treatment as trying for a baby. She has no other gynae conditions. On examination, she looks flushed, is mildly parexic. There is tenderness in the right iliac fossa. However, the patient states that this was more generalized abdominal pain earlier in the day, and the pain increases when stretching her legs. Whilst awaiting ultrasound, the serum beta HCG returns as 4. What's the most likely diagnosis? A. Miscarriage. B. Ectopic pregnancy. C. Endometriosis. D. Ovarian cancer. Or E. Appendicitis. So I'll give you a few seconds just to answer that one. Okay, another minute or two. And try and answer these if you can, because if you get a question wrong, you're more likely to remember it than if you didn't try at all. Okay, so the answer is appendicitis. So I did put this in here as a bit of a trick question, but basically, you know, from reading this, the symptoms are loss of appetite, nausea and vomiting, and fever. And the pains in the right iliac fossa, it's exacerbated by stretching her legs, and her serum beta HCG is 4. So if it's less than 5 for the beta HCG, it means they're not pregnant. So that rules out miscarriage or ectopic pregnancy. And then endometriosis and ovarian cancer, it wouldn't usually cause an acute presentation or these sort of systemic symptoms. And ovarian cancer it peaks at 60 years, so this patient would be quite young for that. And so appendicitis, so periumbilical pain, it's followed by localization in the right lower iliac fossa. Anorexia. Oh, sorry. Are the slides not working? Someone's written. Okay. I'll just finish off reading this one then. Anorexia, loss of appetite and pain on hip extension. The psoas sign is common. Okay, I'll see. I'll unshare and see if I can get it to share again.
They were working for me, Rachel. But yeah, maybe just go back in and out of them and see if that makes any difference.
Try sharing the entire screen. Okay. Is that sharing at all, Owen?
Nothing's come up yet, Rachel. It'll maybe just take a wee minute. That's it up there now. I can see them moving on. Okay, just if you can let us know in the chat if they're moving on for use.
Can you see the questions there?
Yep, I can indeed.
Okay.
Yep.
Sorry about that, everyone. I don't know what happened there. I think maybe just MedAll's playing up a bit. So you probably didn't see that first question then. Apologies. But yeah, it was like a little trick question. So you just need to be aware that whenever you're getting your questions, it's not going to be set out topic wise. So it might be a gynae case, it might be a GI case, it might be sort of a UTI or those sort of bladder cases as well. Thinking of all the organs that are in the pelvis. And so the things that you would be doing for this is investigation, so ultrasound to confirm appendicitis and rule out other gynae conditions such as a ruptured ovarian cyst, ovarian torsion, and the treatment would be laparoscopic appendectomy with prophylactic IV antibiotics. And it's important to remember the antibiotics because they come up in MCQ questions all the time. And I just included that image because I think it's quite useful to memorise. So, case number 2, hopefully you can see it this time. A 28-year-old woman presents to A&E with a 4-hour history of lower abdominal pain. The pain came on suddenly and is colicky in nature. She rates the pain 8 out of 10 and she's feeling very unwell with fever, nausea and vomiting. She is sexually active but is on contraception. On examination, there's tenderness in the right iliac fossa. The serum beta HCG returns as 4 and ultrasound shows an enlarged right ovary with a whirlpool sign. So what's the most likely risk factor? Endometriosis, ovarian mass, ovarian hyperstimulation syndrome, using combined contraception or using progesterone only contraception. So the presentation is very similar to the previous one, but it's not appendicitis this time. Okay, and the answer is ovarian mass. Sorry. Is this the right question? Oh, sorry, what's the most likely risk factor? Yeah, ovarian mass. So to get to the diagnosis in paragraph 1, you're sort of thinking about differentials. So from the lower abdominal pain, sudden nature, fever, nausea and vomiting. You're thinking more appendicitis, ovarian pathology such as a ruptured cyst, ovarian torsion. And then paragraph 2, they're not pregnant because the beta HCG returns as 4. And the whirlpool sign is suggestive of ovarian torsion. So this is a 2-step question, and getting the risk factor, so over 85% of torsions have an ovarian mass, and this predisposes the ovary from rotating on the ligaments and it becomes fixed, restricting the blood supply. And other risk factors for ovarian torsion are being of reproductive age, pregnancy, ovarian hyperstimulation syndrome as well. And just running through these explanations. So it's not really endometriosis. It's not it's usually more chronic and not as acute as this. Ovarian hyperstimulation syndrome, it is a known cause of ovarian torsion, but it's unlikely to occur in this patient as it's usually precipitated by IVF. And then contraception is protective against ovarian torsion. So the next step for ovarian torsion is detorting the ovary using laparoscopic surgery, and that would save fertility, or you can do an oophorectomy and that reduces the risk of recurrence. So with the third case, a 32-year-old woman presents to A&E with a 4-hour history of abdominal pain and light PV bleeding. She rates the pain 8 out of 10. Her last period was 7 weeks ago and she has a history of pelvic inflammatory disease and has been receiving fertility treatment as trying for a baby. On examination, there is generalized tenderness of the abdomen, worse in the right iliac fossa. Ultrasound reveals a 4.5 millimeter mass. Oh no, the slides are stuck again. Owen, would you be able to share your slides? Would that be okay?
Sure. Yep. Sorry, they keep moving on for me, but just in case they're stuck for everybody else, give me 2 wee seconds.
So sorry, guys. We're just having some technical difficulties here.
Okay. Are you able to see if I can hide this sidebar? Is that working okay there now?
Yeah. Can you zoom in a bit more?
Sure.
Oh. Yeah. That's good.
Okay.
So we're on case 3.
Okay.
Yeah. So can everyone see that okay? Sorry. Yeah, okay, good. So yeah, I'll read that out again. A 32-year-old woman presents to A&E with a 4-hour history of abdominal pain and light PV bleeding, and she rates her pain 8 out of 10. Her last period was 7 weeks ago, and she has a history of PID and has been receiving fertility treatment. On examination, there's generalized tenderness of the abdomen, worse in the right iliac fossa. Ultrasound reveals a 45mm mass in the right fallopian tube with multiple adhesions on the left. Her serum beta HCG is 6,500. So what's the most appropriate management? Expectant management, exploratory, laparotomy, laparoscopic salpingectomy, laparoscopic salpinotomy, or methotrexate? Okay, Owen, next slide. So the answer is a laparoscopic salpingotomy. Salpinotomy. Sorry, I can't say that. And if you scroll down, I can give you the reasons why. So looking at the history, she has abdominal pain, PV bleeding, PID. She's obviously pregnant. So in the first paragraph, your differentials are miscarriage, ectopic pregnancy, and infections. And in the second paragraph, you're thinking diagnosis-wise, an ectopic as the patient's pregnant and there is a mass in the right fallopian tube. Okay. So I'm not going to go through what expectant management and exploratory laparotomy are because I cover them later on. But a laparoscopic salpingectomy is usually first line, particularly if the patient is in a lot of pain, if you can see the fetus heartbeat, if the baby's large or the fetus is large and the beta HCG is over 5,000. But the caveat is you need to avoid it if there's contralateral tube damage. So in this patient, she has adhesions in the left fallopian tube. So if you get rid of her right fallopian tube, the chances of her getting pregnant are very low. So on these sort of questions, you need to be looking for whether there's a problem with the other tube. So for this one, it's a laparoscopic salpingotomy, and it is if it's painful, there's a heartbeat, the fetus is large, or the beta HCG is over 5,000. Next slide. So ectopic pregnancy, so the definition of that is implantation of a fertilized ovum outside the uterus, and the most common place is the ampulla of the fallopian tube, which you can see in that diagram. Risk factors for it are damage to the tubes, fertility treatment, so 3% of IVF surgery or IVF pregnancies are ectopic, and use of contraceptives like the copper coil and progesterone only pill. And it usually presents with missed period or confirmed pregnancy, pain, light vaginal bleeding, and shoulder tip pain as it irritates the diaphragm. On examination, there might be abdominal tenderness, and on bimanual examination, there can be cervical excitation. And in one of the things I read, it said don't assess for adnexal masses because it can cause the rupture. So feeling around the ovaries can cause rupture, but I don't know how accurate that is. Investigation wise, you're going to do a transvaginal ultrasound scan, and this will be done in the early pregnancy clinic. They determine the position of the ectopic and the size of it. So if it's less than 35 millimeters, it's considered small, and if it's more than 35, it's considered large. Look for a heartbeat and assess the beta HCG level. And if you can't find the pregnancy on the ultrasound, you should assume it's ectopic if the beta HCG is greater than 1,500. And I've just written sort of the timeline of gestation and growth of the fetus. So at 5 weeks, you can see the gestational sac, 6 weeks, the yolk sac and fetal pole, and 7 weeks, you should see the heartbeat. And the beta HCG is shown there too. And yeah, it can get really high. I think the first time I saw it, I was kind of shocked how high it can get. And they think that the hormone in beta HCG is linked to hyperemesis gravidarum, so it peaks around week 10 usually. Next slide, please. So with an ectopic pregnancy, the management is different for different presentations. So if it's asymptomatic, small, beta HCG is low, and there's no heartbeat, you can consider doing watchful waiting for 48 hours and repeat bloods to see if the beta HCG is going down. And that's usually if you think they're having a miscarriage. So it's going to sort itself out, and you might want to consider surgery. But you would have to consult with very senior people about this, because it's very risky to leave a woman who has an ectopic that might rupture without a good reason to do that. Medical management is if there's no significant pain, they're small, beta HCG is low, and there's no heartbeat. And in this case, IM methotrexate would be given, and it's teratogenic, so you need to give contraception for 3 to 6 months. I think that would be quite a good MCQ question, because you would need to know that in advance. And then surgical, as we talked about before, salpingectomy or salpingotomy. Salpingectomy is first line, and then salpingotomy is second line or first line if there's contralateral tube damage. And then this is rupture. So in rupture, the patient will be hemodynamically unstable, and they'll have pallor, increased cap refill, tachycardic, hypotensive. They might be peritonitic with rebound and guarding. Vaginal exam and transvaginal ultrasound may reveal fullness in the pouch of Douglas, so there might be blood in the back of the pouch of Douglas, and you can see that on the ultrasound. It looks like a big black blob. And for this, you need to do an A to E assessment, trigger massive hemorrhage protocol, and stabilize for surgery. Sorry, Owen, it looks like we're having issues again with the slides.
I'll maybe just come out of that and go back in. I don't know why it's sticking tonight. Let me try and share this again.
I think MedAll has been playing up, because I tried to go to a talk last week and it didn't work either.
I'm just going to try and share my whole screen this time and see does it work a wee bit better. Okay, I can't see it anymore, so are you able to see the slides okay?
I can, yeah. Can everyone else? Alec, can you see? Yeah, okay. It's on 19 now. Great. So A to E assessment. Everyone, write into the chat if it happens again, please. Sorry, it's working on our end, but I think there's just something going wrong with MedAll here. So A to E assessment, trigger massive hemorrhage protocol. Oh, it's gone away. Yeah, there we're back. and stabilize for surgery. So yeah, Owen, next slide, please. Okay, so this is cervical presentations. This is quite good, especially for the men in the audience, as you don't get many chances to see what cervixes look like. And if you're doing smears or speculum exams, this is what you're going to see. So I want you to match the picture to the pathology, and there's no poll for this, so you just have to do it in your head or write it down on a piece of paper. So I'll read out what the different possibilities are: Nabothean follicles or cyst, Gartner's cyst, ectropion, postlets, IUD strings, trichomonas infection, cervical warts, polyp, cervical stenosis, cervical atrophy, leukoplakia, or a normal cervix. And I'll give you 10 seconds to decide A, B, C, and D. What are they? Okay, Owen. We'll reveal the answers. So A is an ectropion. So hopefully you can see that the cells from inside the uterus canal have grown outside into the outer cervix, and they're red and bleed very easily. So patients often present with postcoital bleeding, and when you do a smear, often it bleeds as well when you're brushing it. So that's quite a common presentation, and it's very common in women who are on combined contraceptives. Some doctors feel like it's just a normal variation because it's so common, but you can get treatment for it as well if there's like signs of anemia or if the patient's very worried about it. B is a normal cervix, so it looks nice and pink, healthy. C is an Nabothean cyst, and it's just like that little white, yellowy cyst on the cervix. And D is a polyp, and that can cause bleeding, especially postcoital bleeding. Next slide, please. Okay, and here's 4 more presentations, and same conditions apply on the right side, so I'll let you match them. Okay. So E is IUD strings. So hopefully you can see them. They're sort of poking out towards the bottom left corner. When you put the IUD in, they have really long strings, and then the doctor has to cut them usually till about 2 centimeters below the os, and explain to the patient what they should be feeling if they're doing an internal exam on themselves, because you sort of need to know that the strings are still there. Then F is cervical atrophy. So it's basically common in an older woman when they have lower estrogen, and it can be caused by like postcoital bleeding and uncomfortableness whenever you're having coitus and intercourse. So that's something to watch out for. And also in women who are postmenopausal, they can have a cervical stenosis, or like a very small Oz, which is the opening into the uterus. So that's another thing that you can see. G is cervical warts, so that's the white bit at the bottom. And H is trichomoniasis, which is an infection, and it looks like a strawberry, basically, when you look at the cervix. Next slide. So those are the picture round over, unfortunately. So back to the MCQs. A 25-year-old woman attended the GP for her first cervical screening, and she wants to know what's the highest risk factor for causing cervical cancer. A, HPV 16 and 18 infection, B, HPV 6 and 11 infection, C, smoking, D, lower economic status, or E, combined oral contraceptive pill. Okay, it looks like most people are getting this one, which is good. So I think we can do the answer now, Owen. And the answer is HPV 16 and 18 infection, and that's linked to 70% of cervical cancers. HPV 6 and 11 is not considered carcinogenic, but it can cause cervical warts. They try to trick you with those, so it's quite easy to remember them. So 16 and 18, think cervical cancers. Smoking is a risk factor as well, and it increases risk by twofold, but it's still not as much as HPV. Lower socioeconomic status and combined oral contraceptive is also a risk factor. And remember that the combined contraceptive is protective against ovarian and endometrial, but increases risk of breast and cervical. Okay, and the same patient returns 3 months later to get their smear repeated, and the latest results are shown. So they've had one smear and they've had to come in for a repeat. So they're HPV positive and their cervical cytology is inadequate. Okay, we can see the answers now. So the answer is refer to colposcopy, and that's because the patient has had a repeat smear because it was inadequate the first time. So they've come back 3 months later, and then this is the results, and it's inadequate again. So you need to go to colposcopy because it could just be an endless cycle of not getting the results that you need. It will just keep being inadequate unless they go and get a proper colposcopy done. Next slide, please. A 51-year-old woman attended GP for a cervical screening. 2 years ago, she was positive for high-risk HPV, but cytology was normal. Her repeat after 12 months showed the same results. Oh no, we're stuck again.
Yeah, I have two screens going and it seems to be moving on for me, okay? Hopefully, yeah, I'll extend that it's back now. Is that the same for everybody?
It was working fine until you went full screen, maybe, was it?
Yeah, it's back there now. Is it easier or you doing full screen or
Sorry.
as a like what do you just like here without being full screen?
Uh, yeah, maybe.
Okay, we'll try that. I'll just mute myself and come back again.
Yeah, I think it was working on this version. Can everyone see that okay? Sorry, guys. Okay. So yeah, the question, 51-year-old woman attended GP for screening 2 years ago. She was positive for high-risk HPV. Cytology was normal and her repeat after 12 months showed the same results. Her second repeat was returned and she's now HPV negative. What is the most appropriate next step? Carry out a cervical cytology, repeat smear in 3 months, repeat smear in 12 months, return to routine recall after 3 years, or return to routine recall after 5 years. Perfect. So the answer is return to routine recall every 5 years, and that's because she's over 50. So once you're over 50, it's 5 yearly, and if she was under 49, it would be every 3 years. And yeah, I think everyone else probably realizes where they've gone wrong there. To carry out the cervical cytology, they don't need to do this if it's HPV negative. And yeah, they only do a repeat smear in 3 months if it's inadequate. So cervical screening, the aim of it is to detect malignant changes using a cervical smear, and that wee diagram shows you how it's done. So you put a brush into the os of the cervix and twist it a few times to try to get some cells, and you put it into a pot and then it's sent off to the lab. It's carried out 3 yearly for 25s to 49-year-olds. And if you're 50 to 64, it's 5 yearly screening. And it's not offered to women over 64. You can opt out if you've never been sexually active or if you just don't want it done. And also women with HIV need screened annually. The lab tests have changed recently for Northern Ireland. It's now the same as in mainland. So step 1, they assess for high risk HPV. And the high risk strains we've already talked about are HPV 16 and 18. And there's also other strains which are shown below. And only if those are positive will it be sent to the cytology labs, and they will check to see how the cells look. So if they have a regular nucleus or a perinuclear halo, it'll be classed as dyskaryosis, and it will come back as abnormal cells. And this is the screening pathway. So looking on the left side first, if you're high risk HPV negative, it's just normal recall. And then on the high risk HPV positive, your sample sent to the cytology lab. If it's normal cytology, but you're still high risk positive, high risk HPV positive, you'll be recalled in 12 months to get a repeat. If it's still positive, you get recalled in another 12 months, so that's a total 24 months. And if it's still positive, you go to colposcopy. And if it's negative at any point, you go back into the normal recall. If the cytology is inadequate, you repeat it in 3 months, and if it's still inadequate on the second sample, you go to colposcopy. And if there's abnormal cytology at all, you go straight to colposcopy. And at colposcopy clinic, you can be referred by the doctor if the cervix looks suspicious, or if you're having suspicious symptoms like PV bleeding or postcoital bleeding, and also screening results if they are abnormal or any of the other reasons that I mentioned previously. The investigations they carry out is using acetic acid, and they make abnormal cells white, and they call it acetowhite. And you can see in the pictures below, particularly on the right one, that the cells are all white, so they're abnormal cells. There's also Schleider's iodine solution, which turns normal cells brown, and they can do a punch biopsy or a large loop excision of the transformational zone called LETS at the colposcopy clinic as well, and that's diathermy to remove abnormal cells. So the results, if there's dysplasia, you get it in 3 forms. So CIN1, CIN2, CIN3, and that's mild, moderate, or severe, and it affects 1/3 of the thickness of the epithelial layer in 1, and it'll probably return to normal without treatment, and that's the first image there. In CIN number 2, there is 2/3 of the epithelial affected, and it can progress to cancer. And in CIN3, it's very likely to progress to cancer if untreated, and that would be classed as a carcinoma in situ. And CIN is a cervical intraepithelial neoplasia, just to let you know. And then just a wee bit about cervical cancer. So this is one of the cancers that peaks at a younger age, so it's 25 to 29. And that's why it's important to go to your smears when you're younger, especially. Presentations: postcoital, intermenstrual or postmenopausal bleeding, vaginal discharge, and you might flag up at a routine screening. Risk factors are smoking, HIV, early first intercourse or many sexual partners, high parity, low socioeconomic status, or use of the oral combined contraceptive pill. And the types are squamous cell cancer or adenocarcinoma, and it's diagnosed at colposcopy. And the treatments I'm not going to read out because I'll put you to sleep. But in some of the MCQ questions, they ask what treatment people should get if they still want to maintain their fertility. So you might want to do a LETS or a cone biopsy if it's an early stage. Next slide, please. Okay, and now into common gynae presentations. So this is just my notes on different presentations. So pelvic pain is really common, and it's quite a vague symptom. In acute emergency presentations, we've sort of gone over some of it: ectopic torsion, ruptured cyst, PID. You also need to think about urinary system and bowel system, so UTI and appendicitis. Chronic pain would be more endometriosis, ovarian cysts pressing against things, PID, and then urinary interstitial cystitis and bowel IBD or IPS. And just know that like a patient can have multiple conditions at the same time, so it can get very confusing. Cyclical pain is generally always obs and gynae related, so it might be primary. So this is just normal for them, and it's always been like that. Endometriosis, adenomyosis, PID or fibroids, and severe cyclical pain is called dysmenorrhea. Pain during sex is called dyspareunia, and it can be due to vaginal atrophy, vaginismus, endometriosis, adenomyosis, STI, PID, or interstitial cystitis. And there's probably loads of things that I've forgotten, but those are the main ones that I could think of. And then regarding bleeding, so heavy bleeding is menorrhagia, and it's normal at whenever you first start your periods at menarche, or whenever you're reaching menopause, so in perimenopause, there can be heavy bleeding. Dysfunctional is just there's no cause that anyone can find. Also fibroids or PID. Also remember endocrine disorders such as hypothyroid and bleeding disorders like von Willebrand, intermenstrual bleeding, thinking cancers, polyps, HRT, some contraceptives, particularly the copper coil. If there's no or irregular bleeding, you might be, well, your first thought should be pregnancy and always do a pregnancy test. PCOS is quite common in the population as well. Premature ovarian failure, which is early menopause or menopause. There's endocrine and lifestyle factors. So particularly in anorexia nervosa, eating disorders, excessive exercise in athletes and things, it can be irregular bleeding. And postmenopausal bleeding, thinking endometrial cancer, hyperplasia, cervical polyps, vaginal atrophy, HRT. So back to the questions. A 34-year-old woman has 3 years of lethargy, weakness, constipation, and bloating. During this time, she has progressively heavier and prolonged menstrual bleeding. Prior to this, her cycles were 28 days, with bleeding lasting 5 days. She has no weight loss. Her vital signs are normal. She has conjunctival pallor, and an abdominal examination is unremarkable. Bimanual palpation reveals a bulky, irregular, and enlarged uterus. What option is the most likely diagnosis? Adenomyosis, endometriosis, fibroids, pregnancy, ovarian cancer. Okay, it looks like most people are getting this. Owen, do you want to reveal the answer? So the answer is fibroids. And the next slide shows why. So I usually like to go through MCQ questions and think about why it's not what each option is. So adenomyosis is usually dysmenorrhagia, so pain during periods, which this patient doesn't say she has, and it presents as more diffuse uterine enlargement, so it's not that bulky irregularness. No one chose endometriosis, pregnancy, or cancer. Fibroids is the correct answer because the patient has menorrhagia, GI and anemia symptoms, and the uterus feels enlarged with irregular masses. Okay, next question. A 34-year-old woman who has never been pregnant is referred to the fertility clinic. She has a history of menorrhagia. Initial investigations show she is ovulating and her partner's semen analysis is normal. Bimanual palpation reveals a bulky, irregular, enlarged uterus. The transvaginal ultrasound scan shows a large uterine fibroid distorting the uterine cavity. What is the most appropriate step? Arrange a 3-month trial of the COCP, refer for endometrial ablation, refer for myomectomy, refer for uterine artery embolism. Repeat ultrasound scan in 3 months for spontaneous regression. So I think the important thing in this question is that she's wanting to get pregnant. So keep that in mind. And we'll have a look at the results. So the correct answer is refer for myomectomy. Next slide, please, Owen. So arranging a 3-month trial of the COCP will delay conception, and for large fibroids, it's recommended surgical treatment. And if you were going to give some contraceptive, you would generally give the Mirena coil as its first line for menorrhagia. B, refer for endometrial ablation. You need to avoid that if you want to preserve their fertility. It can cause amenorrhea and increase the chances of ectopics. Referring for uterine artery embolism, it's the same thing. It can stop you having periods, and repeating the ultrasound scan is not going to change anything either. So the right answer is myomectomy, and that's laparoscopic keyhole surgery to remove large fibroids that are over 3 centimeters. And a bit about fibroids. So they're a benign growth of smooth muscle called a leiomyoma. And some MCQs like to try and trick you by using the word leiomyoma instead of a fibroid. So keep that in mind. Presentation, it's very common. 40 to 60% of women have it. And we're stuck again. Oh no. And it's more common in Black ethnicities as well.
Sorry, Rachel, sometimes the slides might just take a week to come through, so I don't know, maybe I'll just come off this again and see does it change.
Is that working for people? It's still stuck.
Okay,
I
just give me.
wonder, Owen, should we? Yeah, we'll
Yeah,
give it one last go, and if not, then
yeah,
maybe need to give up.
yeah. I'll try this.
Everyone should still be able to get access to the slides though at the end, shouldn't they?
Yeah,
So
so I'll
it's
put that.
not wasted, hopefully.
If there's anything that's outstanding, I'm doing an obstetrics talk next Thursday or next Wednesday, actually, because next Thursday's Halloween. So I can sort of quickly go through anything that's we don't get through, but I think that seems to be back there now. Just going off the
Okay.
chat. So work you away.
Okay, so presentation for fibroids, asymptomatic, often just found incidentally on the scans, transvaginal or abdominal scan, and dysmenorrhagia, so painful periods, bloating, menorrhagia, very heavy bleeding, and prolonged periods. Pressure and urinary symptoms, so needing to go very urgently, feeling very bloated, and like there's something pushing on your stomach. Dyspareunia, so pain during sex, and subfertility. Examination will show an irregular enlarged firm, non-tender mass, and investigations, an ultrasound, and then hysteroscopy. Management is a Mirena coil, as I mentioned before, and tranexamic acid to reduce bleeding. And surgical fibroids that are less than 3 centimeters can go to hysteroscopy and get a polypectomy. So hysteroscopy is like it goes in through the uterus. Sorry, it goes into the uterus through the cervix and is less invasive, and they can remove the polyps that way. If it's a larger fibroid, you carry out uterine artery embolism, myomectomy, or hysterectomy. And red degeneration of fibroids is a complication of fibroids. It causes ischemia, infarction, and necrosis. It's often when a patient is pregnant, the fibroid outgrows its blood supply and it kinks and when the uterus sort of is changing shape during pregnancy. And it's more common in larger fibroids. Causes severe abdominal pain and fever and vomiting, and is treated with just rest, fluids, and analgesia, so conservatively. Next question. A 34-year-old woman attends her GP with heavy, painful periods. Periods have been normal previously, but have become debilitating over the past year. Regular paracetamol is not effective, and she's afraid to leave the house as she can soak through her pads. She has 2 children and is using condoms for contraception. Examination shows a diffusely and symmetrically enlarged uterus, which feels boggy, and there's mild tenderness in the abdomen. And the abdomen is distended to the size of a 10-week gestation pregnancy. There's no adnexal tenderness or cervical excitation. Pregnancy test is negative. What's the most likely diagnosis? Chronic endometritis, endometriosis, PID, submucosal myoma, or adenomyosis. Okay, Owen, answer please. So the correct answer is adenomyosis. And if you want to go on to the next slide. So we're just working through them all. Chronic endometritis is a chronic pelvic pain often linked to pregnancy, and it's not cyclical. Endometriosis presents with dysmenorrhea, chronic pelvic pain, dyspareunia, GI and bladder symptoms, and the exam's usually normal. PID is usually caused by an infection like chlamydia, and it causes chronic pelvic pain that's not cyclical, uterine, adnexal, and cervical motion tenderness. A submucosal leiomyoma, which is a fibroid, which you now know, is less likely to be painful. The uterus will feel irregular and might have pressure sensations. And adenomyosis is more common in women who are over 30, have 2 kids or more, and it causes dysmenorrhea, menorrhagia, and an enlarged symmetrical boggy uterus. And a little bit about adenomyosis. Talked about the presentation there and the examination. So the investigation is transvaginal ultrasound scan, and it'll show endometrial thickness. And endometrial thickness does change with the time of month. So in normal people, it can be between 2 to 16 millimeters. And you can also do MRI. Gold standard is a hysterectomy with the histology report, but obviously if you're trying to get pregnant, this is not going to work very well because you won't be able to. Management for it is if you don't want contraception, tranexamic acid, mefenamic acid. Contraception, if it is wanted, Mirena coil is first line. You can also use combined orals or progesterone only. And if referred to a specialist, they can start gonadotrophin releasing hormone analogues, and they induce a menopause-like state. Surgical treatments are endometrial ablation, uterine artery embolism, and hysterectomy. So quite similar to fibroids. Next question. A 32-year-old woman presents to her GP with dysmenorrhea and deep dyspareunia, which is pain during intercourse. She describes this as severe abdominal cramping and backache. During and prior to menstruation, she has a regular menstrual cycle with normal flow. She has no children and no other medical, gynecological, or STI histories. All smears are normal, and on examination she has a fixed retroverted uterus. What's the most likely diagnosis? Adenomyosis, fibroids, endometriosis, ovarian cysts, or PID? Some of you have gone straight in there. You knew exactly what it was. Okay. Reveal the answer. So it's endometriosis, and most of you got that right. The reason why it's endometriosis is the presentation, which is dysmenorrhea and deep dyspareunia, and the examination findings of a fixed uterus suggest that there might be some adhesions in there. So a normal uterus does not feel fixed. The other thing that causes those sort of pelvic adhesions would be PID, but she hasn't had any STIs, so it's less likely, and it doesn't really cause dysmenorrhea. It's more of a chronic pain. Adenomyosis, we've covered that before, and fibroids we've covered before. Sorry, yeah, go on to the next one. So a 24-year-old woman presents to her GP with severe pelvic pain. The pain is excruciating and does not respond to paracetamol. Pain began 6 months ago and starts 3 days prior to the start of her period and continues till her period ends. Periods are regular every 28 days, and she changes her pads every 4 hours. She was 15 years at menarche and until 6 months ago had only mild pains that settled with paracetamol. She's sexually active but uses condoms during intercourse. Abdominal and pelvic exam are unremarkable. What's the next step? Prescribe mefanic acid and review in 2 weeks. Refer for abdominal ultrasound. Continue paracetamol. Review in 2 weeks. Prescribe ibuprofen and refer to gynecology for consent. And insert a intrauterine progesterone system. Okay, this has divided people a bit. Okay, Owen. Next slide, please. So the answer is prescribe ibuprofen and refer to gynecology. This is kind of a mean question because they're all right in their own ways. So the reason why that is the right answer is because you need to, first line for pain is an NSAID, and this patient is presenting with secondary dysmenorrhea, and that should always be referred to gynae. So that's your first thing you need to do, refer to gynae. So treat the pain, refer to gynae. You also might want to refer to do a ultrasound, but it's not an abdominal ultrasound, it would be a transvaginal ultrasound. So that's why that one's not right. The mefenamic acid won't treat the underlying cause, but you can still give it instead of the ibuprofen. Paracetamol, same thing, but it's not actually treating her pain, so you might want to step it up. And the intrauterine progesterone system is not indicated. It will help with menorrhagia, but they still need referred. So, yeah. That one's more thinking about the referral criteria. Endometriosis, it's a common enough condition, and I feel like the more you talk to people, you might hear about it. And here they have it. So it's endometrial-like tissue, which grows outside the uterus, and it follows the hormonal cycle. When it sheds, the lining is irritated, and tissues adjacent to the blood can cause sort of a chronic inflammatory reaction, which is painful and can cause adhesions. So there's two parts to endometriosis. It's the pain during the actual period, and then it's also the pain caused by the adhesions. So it's common in late teens, early 20s, dysmenorrhea, pelvic pain, dyspareunia, so pain during sex, and that's described as deep pain during sex. And cyclical bowel, urinary, shoulder tip pain, PR bleeding. If there's endometrial tissue in the bowel, it can bleed into the bowel, and fertility is usually affected. Examination, as I said, can be normal, can be pelvic pain, can be reduced organ mobility as well. Investigations, a pelvic ultrasound scan, so not an abdominal one, pelvic one, and that's transvaginally. Identify any endometriomas. It can also be normal, so you can't really go off the scans. They're good to confirm, but not good to rule out. MRI can also be useful. There's a new test, a salivary mRNA test. It's not ruled out in the UK, but something to look out for. And the gold standard is laparoscopic visualization, and it's not recommended unless the treatment's failed. So for people to get an official diagnosis of endometriosis, it's often laparoscopic surgery that needs done, and currently I think it's like 10 years before people with endometriosis are officially diagnosed. So it's a crazy waiting time, and you have to go through a lot of treatment steps before you can get to that point. There are different types: superficial, peritoneal, ovarian endometrioma, which is called a chocolate cyst, and you'll see what they look like in the next slide, and deep infiltrating, which is greater than 5 millimeters, invading into tissues. And management is pain management, fertility management, and also gonadotrophin releasing analog management. So for the pain, you can give analgesia, contraception, and triple it up. So you call it back to back. So you do 3 packs of the combined oral contraceptive and then have a week break. So instead of having 12 periods a year, they only have 4 periods a year. So that reduces the bleeding and the pain and the adhesions that come along with that. Can use progesterone only. If patients aren't keen for hormonal contraception, they can use copper coil. And then there's this treatment called gonadotrophin releasing hormone, which I mentioned before, and if you look to the box to the right, the mechanism of it is it basically activates the gonadotrophin releasing hormone receptor, and that increases the FSH and LH secretion. So there's loads of it, and there can be an initial flare of symptoms. And because it's activated, because the receptors are activated, it causes a negative feedback to decrease the LH and FSH secretion, and that will reduce serum estrogen levels. And they usually are fully suppressed at about 21 days, so it takes about 21 days to work. And the side effects of that are menopause symptoms and reduced bone mineral density. And that's a common MCQ question. So gonadotrophin releasing analogues can cause osteoporosis, so you need to add back HRT as well. And then back to the surgical things that can be done. So laparoscopic coagulation, excision, ablation, and usually they do a gonadotrophin releasing analog afterwards for 6 months. You can also have a hysterectomy and a bilateral salpingectomy and oophorectomy. And then for fertility treatments, there's surgical removal of the endometrial lesions, removal of endometriomas, and IVF. And fertility does improve whenever there is surgical removal of the lesions, so it is quite a good treatment. So here are some pictures, and if you've ever been in an endometrial surgery, which you will in fourth year, like it's quite common, you'll see these. So I haven't seen a chocolate cyst before, but it looks like, I don't know, an Easter egg almost inside an ovary, and it's enlarged, and that's just the congealed blood. And the bottom left is the gunshot powder lesions, and that's the endometrial like tissue that's on the peritoneum there. And you can see other adhesions on the bottom right as well. So it's really nasty disease and really debilitating for a lot of people. This is just my comparison table, so you can have a look at that in your own time. It's just an easy way to remember everything, I think. Okay, a 24-year-old woman presents to GP with abdominal pain. She also reports pain during sexual intercourse, has noticed bleeding between her periods, and on examination there's lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness. And there's a vaginal mucopurulent discharge. The doctor tells the patient they are now at increased risk of which condition? So A, acute appendicitis, B, ectopic pregnancy, C, endometriosis, D, ovarian cancer, E, uterine cancer. So it's a two-stepper. Figure out what the diagnosis is, and then figure out what are the complications of that condition. Okay, and the answer is ectopic pregnancy. So this patient has PID, pelvic inflammatory disease, and ectopics are more common in that. Most common cause of PID is chlamydia, and most severe form is gonorrhea, and then there's other causes. It's summed up really nicely on Zero to Finals, so I would suggest you read that. Risk factors: not using barrier contraception, multiple partners, younger age, having STIs, and intrauterine devices as well. So before any doctors put in a IUD, they always swab it to make sure there's no organisms. Presentation is pain, abnormal vaginal discharge, abnormal bleeding, dyspareunia, fever, and dysuria. And examination can show cervical motion tenderness and an inflamed cervix and discharge. So investigations are swabbing, so NAT swabs, high vaginal swabs, syphilis blood tests, inflammatory markers, and rule out ectopics. And there's this question that always comes up in PassMed. I don't know why. It's the Fitzhugh-Curtis syndrome. It's very random, very specific, but it's inflammation of the liver capsule, and it causes adhesions between the liver and peritoneum, and it causes right upper quadrant pain. So if you think a patient has PID and it's talking about the liver and right upper quadrant pain, think Fitzhugh-Curtis. Management refer to GUM clinic, and they do the contact tracing as well. And then there's antibiotics you can start, but you can have a look at that in your own time. Okay, a 62-year-old woman presents to her GP complaining of recurrent vaginal bleeding. The symptoms started 6 months ago. They get worse following sexual intercourse, but there's never any pain. She's never been pregnant, and she took the COCP for 15 years, which she stopped 5 years ago due to the menopause. Her most recent smear from 3 months ago returned negative, and on examination the patient is overweight, the cervix appears normal, and there are no masses or polyps visible. The uterus feels normal in size. What is the most likely cause? Cervical ectropion, cervical cancer, endometrial cancer, uterine cancer, uterine fibroids. Okay, so we'll reveal the answer. And it's endometrial cancer. So just going through the answers, the cervical ectropion, it's not likely as her cervix appears normal, and also that would be more common in a younger patient who's on combined oral contraceptive. Cervical cancer, her smear was normal. No one guessed ovarian cancer, and no one guessed vaginal atrophy either. And endometrial cancer is 60 plus years old with postmenopausal bleeding, null parous, and obese. And it being obese also can cause higher estrogen levels. So there's two sections to endometrial cancer. There's like a pre-cancerous stage called hyperplasia, and that's abnormal proliferation of the endometrial causing a thickening, and it's precancerous with 5% transforming into endometrial cancer. There's two types, simple or complex with atypia, without atypia, and simple or complex with atypia. And with atypia is worse because it means the cells aren't normal, they're not typical. The risk factors, Zero to Finals explains this really well too, but age, obesity, type 2 diabetes, anything that causes unopposed estrogen, or if the patient isn't ovulating. So late menarche, late menopause, early menarche, late menopause, low parity, if the patient has PCOS, HRT with estrogen with no progesterone, and tamoxifen. And I think there was an HRT station in finals last year. I was looking over the finals document, and it said like lots of people forgot about having to add estrogen and progesterone. And there's also hereditary causes like Lynch syndrome, presentations, abnormal bleeding, and investigations, red flag, straight to gynae if a patient has postmenopausal bleeding. Transvaginal scan will show increase in thickness, so greater than 4 millimeters. And hopefully you remember before I mentioned that in a patient who's premenopausal, normal is between 2 to 16 millimeters, so you just need to remember that. Biopsy can be carried out using a pipelle or hysteroscopy. Pipelle is easier to do, but it's less accurate because you're going in blind, whereas hysteroscopy, you can get a more accurate biopsy. Management: if there's no atypia, use progesterones, such as the Mirena coil, and do biopsies every 6 months. And if there's atypical hyperplasia, need to do a total abdominal hysterectomy and bilateral salpingo-oophorectomy because there's a high risk of cancer. And then endometrial cancer. That is the malignant transformation of endometrial cells. And this is one of the rare things where smoking is protective. It's not that protective, so don't be encouraging patients to start smoking. But yeah, it's shown that smoking is protective. And it usually presents in older women, so 65 to 75 years, abnormal bleeding, differentials, you can read through those, just anything that causes bleeding really. And staging, there's 4 different stages. So confined to the uterus, extends into the cervix but not beyond the uterus, extends beyond the uterus but confined to the pelvis, and involves bladder, bowel, or is metastasized as stage 4. And I'm also not going to read all this because I don't think you're going to really be asked it, but it's good to have a look at it just to see. Generally, it's surgery with chemo and radio. And a 27-year-old woman presents to GP with irregular periods. Patient describes oligomenorrhea. Since menarche at 12 years old, her periods occur every 8 weeks. She reports paying for laser hair removal on her upper lip and chin, and on examination the patient has cystic acne. Speculum and bimanual exam are normal. The patient is referred for a transvaginal ultrasound scan and is booked for a blood test. What endocrine markers are most typical of this diagnosis? This one's quite hard, I think. It caught me out when I did it. Okay, will we see the answer? So it's A, a low sex hormone binding globulin concentration. And if you just scroll down. So most people went for testosterone, which is actually what I clicked the first time. But then when I read it back, I was like, oh yeah, that makes sense. So testosterone levels 10 times greater than normal would be more common in an androgen secreting tumor, such as a Leydig cell tumor. And testosterone is normal or mildly elevated in PCOS. But if it was 10 times, you're thinking, geez, that's really high. Something is producing it ectopically, probably a cancer. So sex hormone binding globulin, it will be low or normal because it binds to the free androgens. So if androgens are high and this is binding to it in the blood, that level goes down. And also the liver will produce less of it in PCOS. The LH-FSH ratio increases. LH increases and in ovulation, and FSH doesn't increase, so there's no follicular maturation. And low serum cortisol concentration causes adrenal insufficiency. Raised TSH causes hypothyroidism. So this is PCOS. Hopefully you figured that out. And it causes excessive androgens, insulin, and IGF-1, which inhibits the selective growth and maturations of ovarian follicles, causing ovarian dysfunction. And that's oligomenorrhea or amenorrhea. And hopefully you've learnt the ovarian follicle cycle. It's like an easy thing to forget, but in PCOS it helps to remember it. And presentation is subfertility and infertility, and lots of people who are struggling to get pregnant will be diagnosed with this and have had no clue that they've had it for years. Problems with periods, hirsutism, acne, obesity, acanthosis nigrans, which is common in diabetes as well. So next slide, please. Investigations for it will show raised LH to FSH ratio because the LH is high and the FSH is low. Testosterone may be normal or mildly elevated. Prolactin can be normal or elevated. Sex hormone binding globulin is normal or low. Transvaginal ultrasound is gold standard, and it'll show multiple cysts on the ovaries. So you can see on the right in that image, there's lots of little follicles, and they describe it as a string of pearls. And you can also do the oral glucose tolerance test to see if they are insulin resistant. The criteria for diagnosing PCOS is to do with you need you need 2 out of 3 things, and it's called the Rotterdam criteria. And I just think of it as periods, hyperandrogenism, and ultrasound. So periods, they need to have amenorrhea or oligomenorrhea. And hyperandrogenism, clinical or biochemical signs. So hirsutism, which is excessive hair growth, acne, or elevated testosterone. And then ultrasound, there's loads of different categories for what is classed as polycystic ovaries, but the string of pearls is the main thing. Management, first line is weight reduction pretty much for everything, and a statin if the Q risk is high. For hirsutism and acne, first line is COCP Dianet, and you also need to remember the contraindications. So if a BMI is over 35, COCP is contraindicated. There's also topical creams such as eflornithine, and if they're referred to a specialist dermatologist, they can prescribe spironolactone, flutamide, or finasteride. For infertility, patients with PCOS are referred immediately to the fertility specialists, and they can start ovarian stimulation via an anti-estrogen. So letrozole is first line and clomiphene is second line, and clomiphene has more of a higher risk of causing ovarian hyperstimulation or multiple pregnancies. Metformin can also be used, and gonadotropins. And to regulate an irregular cycle, COCP is used. And a complication of PCOS is endometrial cancer, like we talked about. Okay, we're near the end, guys. Sorry it's taken so long. I think it's just with the technical difficulties. So, a 57-year-old woman presents to her GP practice for the 4th time in the last 2 months. She complains of bloating, mild abdominal pain, and loss of appetite. You've previously referred her for colonoscopy, which showed no malignancy. Despite this, she remains very anxious about cancer, as her mother, grandmother, and sister have all had breast cancer. Which marker is most appropriate to look for? CA125, CA19-9, CA15-3, CEA, or alpha fetoprotein. Looks like most people know this one, so we can show the answer. So these are right. CA125. It's a marker for ovarian cancer or ovarian irritation, and it also will be high in endometriosis, adenomyosis, and those sorts of conditions as well. CA19-9 is pancreatic cancer, CA15-3 is breast cancer, CEA is colorectal cancer, and alpha fetoprotein, liver cancer, and germ cell tumours such as teratoma. You need to know them, they come up. Just learn them off. A 50-year-old lady is undergoing staging for confirmed ovarian cancer. Upon scanning, it's found that the tumour has spread beyond the ovaries, but is still within the pelvis. What stage is her cancer? Okay. And the answer is 2. So it's the pelvis. Well done, everyone who got that. These are the different types of ovarian cancer. So there's surface epithelial cells, germ cells, second cord stromal, and metastases from other organs to the ovaries. And you can read through all of them on your own time. The best way to think of ovarian cancer is to think about the tummy, because it basically presents with abdominal symptoms, bloating, early satiety, so feeling full very quickly, loss of appetite. If there's a mass in the abdomen, it's red flag. If there's ascites in the abdomen, it's red flag gynae. Weight loss, as with any cancer, due to the increased metabolic demands, pelvic or groin pain, and urinary symptoms. So less of a gynae presentation, more of a GI presentation, but always be aware. Risk factors are the BRCA genes, so that's breast cancer genes that they're usually linked to. Always ask about family history, and increased number of ovulations, obesity, smoking, use of clomiphene. Protective factors are reduced ovulation, so using the COCP, breastfeeding, and pregnancy. Investigations are ultrasound findings, which show an ovarian mass, CA125 levels, which are over 35, and if you're less than 40 and have a complex mass, you might want to measure alpha fetoprotein and HCG, which might indicate a teratoma. I did my elective in Vietnam, and they were taking teratomas out. There's about 5 surgeries every day, and I'd never seen one in the UK, and it was the weirdest thing. They're the ones that have like hair and teeth inside them, but they seemed really common over there. So if you want to do obs and gynae, do your elective somewhere abroad and you might see more interesting things that you don't see in the UK. This is the risk of a malignancy index. You can find it on MedCalc. It just talks about the different symptoms and signs on scan that you might see with them, and ultrasound findings for different sizes and types of cysts. So the staging of ovarian cancer, which is what the question was about, stage 1 is confined to the ovary. Stage 2 is spreading past the ovary but inside the pelvis. Stage 3 is past the pelvis but inside the abdomen, and stage 4 is outside the abdomen. And for staging, I always think just look up images and try to memorize it if you can. The management is really complex, and there's so many different types of cancers, as you saw, but it generally involves surgery and chemotherapy. And you'll be glad to know that's the end. I'm so sorry that it took so long, and I'm sorry that there were technical difficulties, but I hope you did learn something. And hopefully, if a question comes up in your progress test or MLA, we'll have covered it. Just wanted to add that in the MLA, there were quite a lot of sexual health questions, so about like different organisms that were in like swab results, and it would say like, what is this diplococci bacteria and what antibiotic would you give for it. So try to learn off the microbiology of sexual health infections and things like that, because that really threw me because we had never done it in the Queen's Progress test before. But I think that was all I wanted to say. If you could just fill out the feedback form, that would be really good.
Yep, thanks very much, Rachel, for that. Apologies, folks, again, just for the the difficulties, but that was out of our controls. So yeah, I've sent the feedback form just into the chat. I think you should also get an email with it if you haven't already filled it out, to save as much feedback as possible. And yeah, thank you for next week we have a respiratory Monday, and then I'm doing an obstetrics talk next Wednesday. So we'll hopefully see as many of you there as we can. And yep, thank you very much for being with us. Have a good evening.